do we have a total of like 1 hour? So Amanda and I will plan for like 20-25 minutes for each, and then we'll leave the rest for questions. Okay.
That's perfect.
Okay. Should I start now?
Yes, you may.
Okay, thank you. Nice to meet you all. I think, in this virtual meeting, actually probably has a wider, audience than otherwise would be in person. I'm Zheng Fan with UNC Chapel Hill. Nice to meet you all. I'm going to focus on the sleep challenges in, patients with Angelman syndrome. What I would do, I will go over the medical part of the sleep and the Angelman syndrome, and then Amanda will go over with the behavior therapy, which is a big part of management for sleep conditions in Angelman. I think this is my introduction slides, and I've been working with the comprehensive Angelman syndrome clinic at CIDD UNC Chapel Hill for 9 years now, and we've seen kids across the country, which is pretty amazing experience for us all. I will go over a little bit on the normal sleep architecture. It's actually quite unique in kids with Angelman syndrome, and the evolution, along time, there are really evolves at different age, and also, the sleep disorders in Angelman syndrome, and go over some of the details about what we know, and there are clearly more challenges that we don't know. So this is actually a very kind of a diagram showing the sleep stages. I think it's actually it's important for us to know, for most people with the overnight for like 8 or 9 hours of sleep, you can see most of us would have 4 or 5 cycles, like 1, 2, 3, 4 or 5 cycles. And then you can see, this is a wake line. This is the dream. The yellow shaded, the yellow area is the dream sleep. And then stage 1, 2 is the light sleep that is not shaded. And then there's stage 3 and stage 4 is shaded in the a little pink color. Those stage 3 and stage 4 now. So stage 3, stage 4 is an old kind of, class way to classify sleep stage. Now it's all lumped into stage 3. So those are the slow wave sleep, the deep sleep we have. As you can see, overnight sleep is really an active process. It's not like, actually throughout the 8 hours for most people, it really evolves over time. So the first half of the night, you have a lot more slow wave sleep, that's deep sleep. And then the second half of the night, you'll have a lot more REM sleep, dream sleep in the early morning, that kind of dominated by the REM sleep. So it's the slow wave sleep is very important. It's really regenerate a lot of the pain burden during the daytime, sleep debt. When someone had a lot of physical activity, they tend to have a more slow wave sleep. And also when they are younger, they tend to have more slow wave sleep. When we're older, we lost our slow wave sleep. And the dream sleep, actually, there are a lot of new functions now, because actually they are has important role, not only like your dreams, you actually have it plays important role in memory reconsolidation. They actually, what does is it actually your brain try to reconnect what you learned during the daytime to your memory, and then will channel and reshuffle and decide where that memory was stored at. So it's like a very active process. And on the top, you can see actually this kind of show you some of the how much those kind of sleep you should have, this is not correct. The slow wave sleep should be about 20% for most of the healthy adults. But the top you can see actually show you the EEG characteristics. The stage 1 is really a transitional sleep, and the stage 2 you have sleep spindles, and then stages 3 and 4 you can see actually is a lot of slow wave sleep, and your brain is really relaxed and in deep sleep, and this probably is REM sleep. This did not marked it right, but as you can see, it's very active. One thing I want to point it out actually is many of us probably may not aware actually, we wake up multiple times at night. Typically, like during the transition, doing those kind of light sleep, stage 2, stage 1, and we wake up at least 5 to 10 times. Most of us, what you do, you would turn around, make yourself comfortable. The place that pressured a lot, the will get relieved, and then you turn around, make yourself comfortable, then you fall back to sleep. However, for kids with like sleep onset association disorder, when they wake up at those time, they look for that particular routine, so stimulations. If this is something that parents need to maintain, then the child will have a prolonged waking up. And so that's sleep stages. So this is a picture show you, how our sleep, in typical developed the person, how their sleep change over time. So this is 5 years. This is 85 years. You can see this shaded blue is the stage 3 sleep. That's deep wave sleep. That's our deep sleep. And you can see when we are young, we have a decent amount of slow wave sleep. Almost like a third of our sleep is slow wave sleep. And then this slow wave really is age related. Once we get older, we lost our deep sleep. And this also lost earlier in people with dementia, in people with like a Parkinson or neurodegenerative disorder. And also in general, men lost the slow wave sleep more so than women. So women actually is able to maintain the slow wave sleep better than men. And you can see the N2 sleep, that's a sleep spindle sleep, and it remains almost kind of consistent throughout our lifespan. And the REM sleep also remains relatively stable, like 10, 20%. And in kids, younger than 5, they have a lot more REM sleep than older people would. And you can see one of the features, this called a WASO, is wake after sleep onset. That would be, waking up at night. You can see this is also associated with gets worse more when we aged. So that's, all the older, the people elderly will tell you, they wake up in the middle of the night a lot more often than when they are younger. So you can see this really kind of summarize the general, the trend and evolution for our sleep architecture evolves over time. And what's in kids with Angelman syndrome or patients with Angelman syndrome, their sleep, the duration you can see. So this would be 8 hours here, and the duration is reduced, and also the kids with Angelman has reduced the N2 sleep, and the N3 sleep is a little hard to truly scored correctly. We'll talk a little more about the unique sleep architecture in patients with Angelman syndrome. So this is a kind of it's a recommendation from Sleep Foundation. As you can see, especially for kids. So we often, parents would ask, how long should my child sleep, right? So it's really age dependent. You can say, from our newborn infant to the older, and that our sleep duration reduces over time. Now we are very young, the newborn neonates, many of them need 15, 16, 17 hours because their brain needs to be matured. That really is the amount of the sleep they really need. They also have a lot of REM sleep. 50% of them, more than 50% of them are REM sleep. And so you can see, the way to remember this, actually, I think, a little easy to remember them would it be, for young adults, roughly on average, they need like, 8 hours sleep. In theory, many of the teenager and the young adults actually need 9 hours of sleep. But it's individual different. And the way you could say, whether I get enough sleep, because, some people don't need that amount of sleep, is you should not have a lot of trouble waking up in the morning. And you should actually, typically rule of the thumb, have at least half of the time waking up on your own rather than all waking up by your alarm clock in the morning. Okay. And also you have a normal daytime function. If you have those things, then you probably are getting enough of your sleep. And most of the adults needs 8 hours, if not more. And the easy way to remember this is roughly actually for a 10-year-old to have 10 hours sleep, roughly. And then the younger one, they need more. The toddler, 2-year-old, remember they need at least 12 hours sleep. So that's kind of like how I would remember as a ballpark rather than kind of like remember all those numbers. And there are big variation about amount of sleep we need. So kind of like when they are newborn, they need 15, 18 hours of sleep. And then 2 years, they need at least, most of them need at least like a 12 hours sleep, toddler. And then 10 years, they need a 10 hours sleep. And for most teenagers, actually, they need 9 hours sleep. And then for adults, they need 8 hours sleep. So that's a ballpark. You can see actually some people don't need a lot of sleep than others, but most of us would need those amount of sleep. Okay. So this is a very brief slide. So I'm not going to go over this because I think many of those have been talked. And this has collected, all those cute pictures of our kids with Angelman syndrome. So what I'm going to go over is there is this bar covering the sleep disorders in Angelman syndrome. This is kind of like a summary slide. I will later on have another summary slides. So I will go over a bit like the parental concerns, which are very valid concerns, and the typical features of the sleep architecture in Angelman kids, and the common things we've seen, the frequent waking at night, and the sleep awake cycle, and the nighttime behaviors, and some other things, and also the risk for sleep apnea, all those things. So let me see. Sorry about this. Okay, so this slide goes over with, let me see. This slide goes over with mostly actually obtained by questionnaire, parental report, but they really are very important aspects of the sleep complaints in Angelman kids. It's quite common as you guys are parents would agree with me. Sleep can be a big challenge in taking care of your kids, your child. And it's very common, 20 to 80% of family reports, there are some concern about the sleep for their child with Angelman syndrome. And the most severe problem age is 2 to 6 years. This is also an age that, sleep habits, hygiene, all those things are formed. They also have very active brain at that time. And also, individuals with Angelman syndrome have difficulty with the multiple aspects of the sleep, initiation of sleep and waking up at night, and also, reduce the total sleep time. They typically don't have that much kind of a daytime sleepiness, rather than, they are a bit hyperactive. And they are nocturnal. They also moves more than other kids, and many of them have enuresis, bruxism, sleep terror, sleep walking, and so all those associated conditions are more common in kids with in patients with Angelman syndrome. And also the presence of epilepsy often is associated with, more problem. In other way, you also can think about, both sleep and epilepsy reflecting our brain function. So for the kids who's a bit more severely affected, they tend to have difficulty with their epilepsy and epilepsy control. And so do their sleep architecture. If you think about, same thing, the sleep is a function of the brain. So they tend to have a bit more trouble with those, and in the kids with larger deletion. It's more than half of the patients, their parents report their concerns with their sleep at night and also seizures. Once they get older, they actually the frequency of nighttime wakings actually decrease with age, as the early preschool age and the early school elementary age is the time. It's very important to form a sleep habit, and also more challenging for parents to handle. Poor sleep quality can really negatively impact neurocognitive development. And this is something we say it's kind of like bi-directional. The sleep affected their behavior during the day, and also their level of function affected their sleep. So there are enough evidence there, like if you really treat the sleep as an independent risk factor to try to kind of improve their sleep quality and the duration at night, they really improve their daytime function, their behavior, their overall neurocognitive development. So sleep clearly plays a big role there. This is kind of very similar to another disorder, like the people with depression. There are very strong evidence now for people with depression. If you treat their insomnia, their sleep disorder as an independent fact, improve their sleep, really improve their depression outcome treatment. So this is kind of like in a very similar way analogy. If you improve the sleep, then their seizure control, their neurodevelopment can be improved when sleep is improved. So that's why actually the behavior therapy and others are very, very important in kids with Angelman syndrome. And also those questionnaire also revealed, taking care of a child with Angelman syndrome is really day and night, 24/7 duty. It plays a lot on parents, their psychological burden. So I think it's very important for the parents to seek for help from their immediate family, their community, and it's very hard work, and at times lifelong. Some of the parents taking care of their adult children with Angelman syndrome. So it's very, very significant about a psychological burden for parents. Sleep architecture, as we mentioned about, one of the very clear significant features of the sleep architecture is if you remember the picture I just showed you guys, 4 or 5 cycles, and the kids with the Angelman syndrome, they tend to go through shorter, and for most normal kids, neurodevelopmentally typical developmental kids and adults, most of them have each cycle is about 90 minutes, and the kids are a little shorter, 4 or 5, even 6 cycles. For kids with Angelman, their cycles tends to be shorter, and also they tend to be more fragmented, waking up, breakdown in their sleep cycle. So their sleep architecture is quite different. If you think about the reason for that, it's really our sleep architecture is intrinsic to their brain. It's a part of their brain function. When the brain function is affected by Angelman syndrome, their sleep architecture is different. And this slide kind of highlights a little bit the typical challenges we're facing when we're staging the sleep stages in kids with Angelman syndrome. It's very challenging, especially if the sleep study is not done in a very kind of like a center that they know how to score the kids with Angelman syndrome. The sleep stages often are not reliably scored. Major part of the reason for that is because actually the the delta slowing, the high amplitude EEG in Angelman syndrome during the day and in the sleep can often really confusing for the sleep tech to score them. They often are scored as N3 slow wave sleep. And also there are recent studies about the sleep spindles and the K complexes, which is the feature for stage 2 sleep, are reducing Angelman kids. And also the REM sleep is reduced in kids with Angelman syndrome. So shortened sleep and more waking up, and also their sleep stages are a little bit different. They have a less into the sleep spindle stage. They have less REM sleep, and then their slow wave sleep has share common features with those kind of high amplitude delta activities during the daytime. And so we kind of mentioned some of those already. And also the other thing is the sleep-wake transition disorder has been seen in kids with Angelman more frequent. Those would include those kind of nighttime movements, hypnotic startles and the nighttime movements. There's not a lot of study about periodic limb movements in Angelman syndrome. In kids with Angelman, I would say, recently there are more data, scientific evidence about the importance of, I don't think I have another slide. No, I don't have, okay, so I'm gonna mention that here. So the importance of iron storage in, restless sleep and periodic movements in any kids actually. And it's also known the kids, young kids, especially toddler age kids, regardless whether they have Angelman syndrome or not, it's very common they have low iron storage. The way to check that is the pediatrician also can check. This would be ferritin and iron panel. And the goal for ferritin is, about 50. So you at least want this to be about 30 or 40. And when this is improved, often the kids will have a more consolidated sleep at night in any kids, regardless whether they are neurodevelopmentally normal kids or with medical condition, including Angelman. So I think that's something we need to keep in mind. I don't think I have a slide about it. So check the iron storage if you can remember. That can be easily checked by the pediatrician. At the pediatrician's office would be ferritin and the iron panel. And those are very important as iron actually plays as a cofactor for some neurotransmitter synthesized in our brain. So, rhythmic movements and waking up, those are all more common in patients with Angelman. And the sleep disordered breathing, like sleep apnea, actually there's not a lot of data out there, just because many kids with patients with Angelman syndrome, they cannot tolerate a sleep study in the lab. So they are not allowed, but for the limited data we know, patients with Angelman syndrome are at a high risk for sleep disorder breathing, both for central apnea and obstructive apnea. And there are some data suggest the central apnea can be associated with some seizure medicine, like benzos, those are commonly used, and benzodiazepines. But the data is not 100%, and it's still evolving, and there are more knowledge we know about this field over time. But there are some concerns about this. I would say, for any kids, patients with Angelman syndrome, if they have, higher BMI, I know most of them have lower BMI, and also big tongue, and also if on pretty high dose of some of the seizure medicine, including benzodiazepines and also Depakote, then we kind of need to pay attention to see whether they have central apnea. And this also, as a parent, you could at times can see whether the patient has witnessed apnea. That means they hold their breathing and they stop breathing periodically in their sleep. I think that's something we need to keep in mind if we do have enough concerns, and an overnight sleep study would be the way to answer that question. Movements in the nocturnal events is fairly common, and we had a little, we touched on the periodic limb movements, and also restless sleep at night can be associated with iron storage, and also the other movements also are more common, enuresis, bruxism, night terror, and night walking. And so this night sleep talking, this is not really that because most kids, they wouldn't really talk that much. But the movements, the more movement in their sleep, including body rocking, body rolling, and head banging, are a bit more common in patients with Angelman syndrome, and sometimes can last beyond, persistent beyond the early age. So I'm gonna, I think I have a few more slides, and then I will turn this to Amanda for the behavior management. So in terms of medical management for Angelman syndrome, melatonin has been studied. There are multiple studies out there. The kids, the patient with Angelman syndrome, they have a lower level of melatonin secretion when it's getting dark outside, though. So think about the melatonin secretion is reflecting a brain function. And when it's dark outside, our brain would start to secrete melatonin to make us ready for sleep. And the patient with Angelman syndrome, that response of release melatonin is a bit more damped. So they don't release enough melatonin. That plays one part in their trouble with their sleep, but not all. And one thing need to kind of keep in mind is physiological melatonin secretion, in response to low lighting is low. For adults, roughly is estimated around 1 milligram. For kids, is 0.3, 0.5 milligram. So you can see, some of the study use a very high dose. This actually can be, can be disruptive to their circadian rhythm, endogenous secretion. However, there are enough studies out there, the randomized trial of melatonin in Angelman syndrome to see whether they are beneficial. Different studies use different doses, anywhere from 0.5 to 9 or 10 milligram. Or to say, very few of those studies actually studied the long term. Very few of those studies studied the long term, and some of the circadian rhythm expert would kind of suggest people to use as needed melatonin. I feel like many parents, if you ask them, they will say long-term use of melatonin lost its effect. I think actually probably would be very reasonable you use melatonin as needed. Like if and many kids with Angelman syndrome will have these periods, their periods of days, they become more hyperactive, have trouble with their sleep. So that would be the days you can clearly use melatonin. And also in our experience, melatonin uses staggered dose. 2 doses can be quite effective. What you do is like we typically would not recommend more than 3 milligram. We use anyone from 0.5 to 3 milligram. 1 dose at bedtime, another dose about 2 hours before the bedtime. That early dose is able to kind of quiet them down, prepare them ready for sleep. And also another thing for parents to remember, the effect from melatonin is it's not hypnotic, so it's not going to really make kids sleep right away, right? But rather than it actually quiets the child down and makes them ready for sleep. And also melatonin is very effective to move the sleep onset. At times by using that 2 staggered dose, you're able to move that sleep onset earlier. So I did not have another slide, but so most of the melatonin study has shown they do improve their sleep latency a bit. So they will kind of be able to, fall asleep a little earlier, and then increase that. Typically is like 10 minutes 15 minutes earlier, and increase their total sleep, and most of the time it's like 20 to 30 minutes, and then decrease their nighttime awakening. So that's the effect you look for. It's not hypnotic. It's not like a clonidine very strong, and also it's not like some other medications. Okay, and some kids also have responded to gabapentin for nighttime waking, and which is relatively benign. That probably would be preferred than some more psychoactive medications like a benzodiazepine or those kind of things. And parasomnia is fairly common, in kids with Angelman syndrome. It's also anyone with a seizure disorder, they are a bit more likely to have it. And there are, some research and the future directions, as you all aware, this, antisense oligo and the gene therapy targeting the underlying cause of UBE3A deficiency. It's really, really exciting. And most of the time when the brain disorder is treated, their sleep should get better as well. There are enough evidence their circadian rhythm dysfunction, the circadian rhythm is disrupted. And also, there are a lot of basic research about the molecular biology of the pathophysiology of Angelman syndrome and other things. And so I think this is my last slide. I'm gonna summarize this very quick and turn over to Amanda. So, the sleep complaints are common, as we talked about, decreased duration, fragmented, sleep at night, and also nighttime wakings. And also this sleep and also the disorder of Angelman plays big role in parents, psychological burden. I would say the parents, they need to take care of themselves as well, not feel like you can do everything by yourself, okay? And the sleep architecture is very abnormal in kids and patients with Angelman syndrome. And also we have challenges about accurately staging the sleep studies as well in most time. And however, it's commonly seen on the reduced sleep spindle of reduced N2 sleep and the reduced REM sleep have been seen. And also nocturnal seizure can play a negative role in both the sleep architecture and the movements and many other things. And it is, despite with insufficient data, but there are enough literature out there, sleep disorder breathing can be a concern. So we kind of need to be a little vigilant on that. Management, I would say behavior is a very, very important aspect. More important than many other medications and other things. And I'm going to turn over this to Amanda and stop the sharing. And then I think we'll have some question sessions afterwards. Amanda, I think you're still muted. Yeah.
Hi guys, can you hear me now? My name is Amanda. I'm a nurse practitioner in the Angelman syndrome clinic, actually at Mass General Hospital for Children up in Boston. So today I'm going to talk to you about some of the behavioral stuff, and I'll touch lightly on medications, but very lightly. So things we're going to talk about today is why sleep is important, common sleep problems in Angelman syndrome, and managing some of those sleep problems. So why is sleep important? I really like this chart. It's Maslow's hierarchy of needs, and it shows, that bottom baseline thing that we need. Sleep is on there. It's right there with air, water, and food. So we can see how important that is in reaching all the other things that we need in life. So, how can lack of sleep prevent kiddos with Angelman syndrome? So it can decrease your seizure threshold, and seizures and sleep are kind of this vicious circle. Seizures make your sleep worse, and poor sleep makes your seizures worse. So it's kind of this vicious circle that we try to fix. It can also cause daytime fatigue and tiredness. So this can mean falling asleep at inopportune times, such as during the school day. It can also mean an increase in daytime napping, especially when naps may not be age appropriate. So that can cause your sleep schedule to be off. It can also cause an increase in behavioral difficulties, so hyperactivity, oppositional and defiant behaviors. Some kids become very aggressive, and a lot of kids are very impulsive when they're more tired. It can also slow down your physical development. So when you're tired, your brain doesn't function like it should. Therefore, your neurons don't function as they should, and your neurons is what helps make your body move. But in addition to that, it can decrease your ability to repair your stress and increase your stress response. So what does that all lead to? Decreased performance in your therapies. And we all know our kiddos, really benefit from their therapies. It can also slow down academic progress. And so, sleep is when we commit all of the things we've learned during the day to our memory. And so if we aren't sleeping, it's harder for us to commit those things that we've learned to memory, and it kind of just progresses kind of like a snowballs as we go along. And I'm sure some of our parents understand when their kids aren't sleeping, it's very difficult to organize your thoughts, which is, kind of central to learning during school. It can also complicate medical comorbidities. A lot of our angels have anxiety. So lack of sleep can make that worse and makes, I think as Dr. Fan presented, depression or irritability, those kind of things. So considerations to help improve sleep. So first, we're going to rule out medical complications. One of the things I do is I will draw a set of labs. Sometimes our kiddos, as Dr. Fan mentioned, have low iron, which can, make some periodic limb type movements. I have had some kiddos with vitamin D that have had some low vitamin D that have had some kind of sleep problems. Other things we look at are reflux and constipation. And some people ask how constipation can make sleep worse. That was a big question before. And, if it can't go out, it has to come up. So usually constipation will worsen reflux. And the reflux is just really irritating to kids when they're trying to sleep. The other thing is seizures. Probably one of the most important things is we make sure your seizures aren't contributing to sleep problems. The next thing I do is sleep schedule, and we'll talk about that more in a minute. And then the last thing is medications. And I think that sleep schedule is very important in this, that if you don't have a good sleep schedule, medications are just kind of a Band-Aid for an underlying issue. So sleep schedule, we're going to make sure they have an appropriate sleep environment, determine the appropriate time in bed for your child, and having a consistent bedtime routine. You're going to do this 7 days per week. You want to put your child to bed drowsy but awake. And if they cry out or call out, you want to not respond immediately. And we'll talk about more of this in a little bit. You also want to just set an established wake time that works with their schedule that they can maintain 7 days per week. So this is a chart for the time required in bed. And I like this chart. I've kind of combined a couple charts because it talks about the total numbers of hours of time required in bed, but it also discusses sleep and what should be nighttime sleep, daytime sleep, and the number of naps. And I will make sure you guys can see this afterwards. So sleep practices, so sleep environment. So safety is the first thing. Some kiddos need an enclosed bed or a mattress on the floor to make sure they aren't falling out of bed and bonking their heads. You just want to make sure the room is safe and remove any harmful things from the room. This is kind of where the use of gates comes in. I really promote the use of gates if they like to escape out of their room. You don't want them running around the house in the middle of the night, or sometimes kids open doors and get out. And so if you use gates, you can just make their sleeping area one big sleeping area. And then some parents use nightlights. Nightlights can interfere with melatonin secretion and circadian rhythm patterns. So that should be considered. Other kind of more simple things, room you want to be dark, quiet, and cool. And we kind of already talked about beds, but some kids require an enclosed bed, mattress on the floor, and some of them are fine sleeping, in a regular bed with railings. So bedtime routine, this should be very specific and predictable. It should be the same from day to day, weekday to weekend. And the routine should be short. You want it to be 20 to 45 minutes long and involve 3 to 4 activities. The routine should be performed in the child's room, not the parent's room, so they don't get the wrong idea on where they're sleeping. And if the routine starts in the bathroom, you want to make sure you're kind of gradually moving towards the child's bedroom. One thing I recommend is putting things that they love doing last. So it's like a reward. A lot of our angels love water and bath time. So if they really hate brushing their teeth, brush their teeth. And then once they brush their teeth, they get that prize of getting to have bathtub time. And then another thing that really seems to help them so that they understand that this is something that's going to happen every night and it's a routine and it's going to be consistent, is to post visual pictures in the order that things are going to go, so that they understand how the routine is going to go every night. And a lot of times this can reduce negative nighttime behaviors. And you don't want to do the stimulating things that are very stimulating, or things that are going to possibly make them very angry close to bed, which is why I recommend doing the things they don't like to do first, because you don't want to stimulate them more right before bedtime. So common sleep problems that we see. So bedtime resistance. With this, you're going to set limits and establish those clear bedtime rules. It's easier said than done, I know. So sometimes we will use medication to kind of help parents establish those routines and rules with their kiddos, and then gradually take the medication away. But in this situation, consistency is key. So like I said, day to day, week to weekend, same routine. You're going to focus on positive behaviors instead of the negative behaviors. So, if they're doing something really good, you're going to compliment them on it. And if you can, if it's possible, and they're safe, just ignore those negative behaviors. And then you want to ignore those bedtime protests. So you're going to firmly and calmly tell them it's time to go to bed and continue on with the routine. You're just going to, keep on marching. And one thing, you don't want to ask if they're ready for bed. You want to say it's time for bed. You don't want to give them that choice to say, oh no, I'm not ready for bed. I want to, hang out with mom and dad until the wee hours of the morning. Let's see. And then if you put them in bed and they come out of the room, this is where the gates come in really handy. You use gates, or you can continually return them to bed. When you return them to bed, you want to make sure that you want them to know that you're not an exciting person at this time. And so you just want to be boring and very quick, return them to bed, and it's time for bed, let them know that, and you're going to return to your bed. And this can be kind of cumbersome. So I have a few other tricks and tips to work with that. The other thing that is very common is actually wanting parents to sleep with them. So in order to kind of fix this problem, I usually will start with the checking in method. And during that, you're going to put your child to bed. And then you're going to say, after, you do your bedtime routine, you're going to put your child to bed, and then you're going to say, oh, mommy's got to go, or daddy's got to go brush their teeth. And you're going to come back, or go brush your teeth, and you're going to come back within 3 to 5 minutes. Some kids can't wait that long. So, some kids, it needs to be 1 to 3 minutes. You're going to come back and check on them. And then, oh goodness, mommy or daddy forgot to, put the laundry in the dryer. So you're going to leave and you're going to come back, and you're going to keep doing that until they've fallen asleep on their own. Because sometimes we kind of run into this little trap where parents fall asleep with the child. Then when they wake up in the middle of the night, the last thing they remember is having that parent near them. And so then they want to go search for the parent because they don't know where mom or dad's gone. Sometimes our kiddos are a little more stubborn and they don't respond to the checking in. So we'll do a gradual extinction. And that just means, gradually moving yourself out of the room by you can put a mattress on the bed or on the floor, or a sleeping bag on the floor. And you're just going to gradually move yourself out of the room over time. The other thing that we run into a lot is frequent nighttime awakenings. And this is where a good sleep schedule comes in. And it also helps with bedtime resistance. We want to consolidate their sleep schedule to make sure their pressure to sleep is strong. So during those lighter periods of sleep, they aren't wanting to get up out of bed and party. We all have, lighter periods of sleep and deeper periods of sleep. And, most of us are just so tired, we roll over and fall back asleep. But sometimes if pressure to sleep is not strong enough, our kiddos will, wake up and want to party in the middle of the night. So that's where a good sleep schedule comes in handy. The other thing you can do during frequent nighttime awakenings is you can allow them to cry it out. Some parents or ignore the crying out. Some parents are very against that because they feel like it might affect them, but there is a study of about almost 2,000 kids that showed that when you use the crying out method selectively and just respond to the very specific needs, it can decrease problematic behaviors, and it does not cause any social emotional developmental problems. The other thing you can do if crying it out's not your thing is you can check in. Again, you want the checking in visits to be very brief. You're going to stop in, say it's time for bedtime, be very brief, less than 1 minute. Do no stimulating activities. You don't want to rub their back or say, oh, it's okay. You're just going to check in. Mommy's here, daddy's here, and you're going to leave. You don't want them to be think that this is a fun time. They should get out of bed. You want to reassure them and enforce limits. So kind of common sleep conundrums. So the crib to bed transition, that's usually a tough one. Some kiddos aren't ready to be out of their crib, but they aren't necessarily safe in their crib. So this is where, the covered beds come in handy, or putting the mattress on the floor, just making sure they're safe. Some parents have trouble with them leaving their bedroom once they've transitioned to a crib. This is again where the gates come in handy. You can make their room basically into essentially one giant crib by putting that gate on the door. You just want to make sure things are safe. So everything's bolted to the walls. I've had some parents take down curtains so that they don't, and make sure they only have blinds so that they don't pull the curtains off the wall and hurt themselves. Just make sure everything is secure and safe. Naps, usually kiddos eliminate their naps between 3 to 4 years of age is when they eliminate naps. I know some of our parents think their kiddos need extra sleep because they have seizures and stuff. That isn't necessarily the case. If they're actively having seizures, they are going to be more tired and require sleep. But if their seizures are well controlled, their sleep schedule is going to be, pretty consistent with the recommendations that I showed you on a previous slide. And then nighttime feedings. Kiddos can usually sleep through the night without eating between 4 to 6 months. So you want to feed them right before bed, put them to bed drowsy but awake. And, then if they get up and want feedings, that's when you can, do the checking in method or allow them to cry it out. And then pacifier use. So pacifier use can be good a study showed that can be good between 2 to 6 months of age. It can reduce the rates of SID, but after about 6 months, it can cause problems with dentition. It can cause actually increased ear infections, and it can actually decrease oral motor development because they can't move their mouth as much when that pacifier is in there. So the other thing that happens is a lot of the time during the night, pacifiers will fall out of their mouth, and that when they wake up, they might be in a lighter period of sleep, but instead of rolling over, they get up and they look for their pacifier. I have had parents say, oh, we keep 5 pacifiers in the bed so that they can find them. Usually we can decrease nighttime awakenings by taking away the pacifier. It's a kind of unfortunate happening for a few days after you take away the pacifier, but usually they get over it and it's fine. The next thing I'm going to talk about is electronics, actually. And studies show that when phones are used to help regulate distress in children, so like if they're throwing a tantrum, at that really inopportune time, and we hand them the phone and say, here, entertain themselves, it can increase the time it takes to fall asleep at night and decrease sleep time, actually. And the reason for that is because they think it decreases children's ability to self-soothe. But using these blue light emitting devices, so TV, iPad, iPhone, they can throw off your circadian rhythm and decrease or slow the release of melatonin. So it takes longer time for your dim light melatonin to be released when you're using electronics. I usually recommend to stop the electronics about 2 hours before bed. I understand that in some instances, this is kind of a survival technique. So I looked up, there are studies that show that turning the red light on iPads and iPhones actually improves the issue with the blue light. So I've looked up ways to turn on the red light on your electronic devices. I'm an iPhone user, so I was able to kind of play with these ideas and figure them out. The Samsung ones I had to look up, and I tested one with a family member that has a Samsung, so that should work too. With the iPhone, excuse me, you're going to change the color filters, but you can also do something called night shift, which automatically turns it on and off, so you don't have to hit the side color filter. And then depending on the age of your iPad, the red light function will function much like your iPhone does when you're trying to turn on the red light on there. Once we've done sleep schedule and we have kind of ruled out all of our medical issues, developed a good sleep schedule, and dealt with all the behavioral difficulties, then we'll look at medications. And sometimes we use medications to kind of help us get on track with the behavioral modifications we're trying to make. But medications are a very in-depth conversation, and different sleep medications work different for different sleep problems. So it's hard to say this medication is good for this kid or this kid. So initially, what I do is I'll try to optimize seizure medication to help with sleep. And then I always encourage parents to remember that, every child is different, and they may present with different sleep problems. So one medication we try for one child might not be good for another child. So there, is kind of a plethora of medications we use. We usually start with melatonin. My little thing with melatonin is you want to make sure that it's either pharmaceutical grade, or there's a little seal on the side of it that says it's FDA monitored. So you make sure you're getting the same dose of melatonin every month. There's actually a study of over 100 melatonins that was done. And because that they're over the counter and not FDA regulated, it showed that some had more melatonin in it than it said, some didn't have any, and some had other things in it that you might not be giving your child. And then other medications we use, gabapentin, trazodone, sometimes I'll use some Seroquel. Those can all help with sleep too, but they're for different reasons, and like I said, they work differently for each child. So I guess we'll turn it over for questions at this time. So it looks like, what safe sleep options are there for bottom bunks? So in this instance, you can get the little rails that you can either screw onto the bunk bed, or there's ones that slide under the mattress. I think the ones that slide under the mattress are a little less effective. But those are probably the two best ones. I do know that there is it's kind of like an enclosed bed, but I've seen it, you can hook it up to bunk beds to kind of make it an enclosed space. I am honestly not sure about the 5-HTP or the suntheanine for sleep aid. I've never used them. Maybe Dr. Fan can answer more on that.
Yeah, I don't know. I can add that much. So for the first question, I don't know the detail, but actually it might be worth to ask other parents. I think, I have a few, I'm always nicely surprised by how resourceful for some of the parents are. And, some of the parents I've seen, they actually find other resources, build up the tent for their child, build up some beds for. So actually, I would say ask other parents, and maybe they will give you a much better idea. That's for badly. The second question, I don't know about this. I think, for a lot of alternative medicine, the herbal supplements, in general, they are not very well studied, and not talking about studied in this population with Angelman, unless, you know more about it. But I think in general, rule of the thumb is this needs to be something safe first. 5-HTP, people use that to increase the serotonin, and also that some I don't know, theanine. If I remember, this is kind of something related with the tea extract. I don't know the details. I think, the supplements, you want to make sure first, if you want to give it a try, it's safe, it's good quality, it's not mixed with other potential toxins. And also maybe, as parents, you can try yourself first to see how it does. And in general, if you have any concern about this may be harmful, I would say not try it.
And then there's a question about taking longer than 20 minutes in bed before the onset of sleep. So most of the time this can be helped with a consolidated sleep schedule that makes that pressure to sleep stronger, and making sure, bedtimes are consistent throughout the week. Because I know sometimes when we allow kiddos to sleep in later on the weekends, because we think that they're tired and they need more sleep, on Sunday night, it's time to go to bed. But because they've been in bed longer, they have more difficulty falling asleep. And as far as darkening the room during daytime naps, you're just going to make sure that the room is, cool, dark, and quiet. So if that means having curtains or blinds on the windows, that might help them sleep a little bit. But you just want to make sure that they're not sleeping too much, their nap times are appropriate for their age, and kind of their sleep schedule is consolidated. And some kids, require more sleep and some kids require less. That chart that I showed before is kind of just a general idea of where they should be. But I would say most of our angels require a little less than the typically developing kid. And then let's see here.
Yeah, so to add to the question Janet has, in general, the average sleep onset, it does take 20 to 25 minutes for just in general. So that is actually not that unusual, but if it's like, more than 40 minutes and 50 minutes, then that's way too long. And also for the daytime napping, a lot of time, I don't know how old your child is, for the kids who's, older than 4 or 5, if he or she was still nap, you do not want them to nap more than 40 minutes, so 45 minutes would be maximum. As if you do go longer than that, the kids will go to deeper sleep. That will reduce the drive for nighttime sleep. So depends on how old is your child, to just make sure the daytime nap duration is not too long. So your nighttime sleep drive is not going to be, interfered by the daytime napping.
And then Cindy, it looks like your 15-year-old's waking up in the night. So again, usually I'll work on consolidating sleep schedule in this situation. And then a lot of the times those behaviors kind of are from anxiety or those kinds of things. So consolidated sleep schedule to make that pressure to sleep stronger. And then if that doesn't work, sometimes I'll use a sleep medication that kind of helps with anxiety a little more. So gabapentin can help with anxiety. And so that will kind of help with that sometimes. And then Paula.
Yeah,
sorry, go for Dr. Zheng.
Add on a couple of things. I think the melatonin, even for a 15-year-old, I would say try 1 to 3 milligram, no more than 3 milligram. And also do try the staggered dose, 1 dose at bedtime and another dose 2 hours before. And we have seen many families feel like 2 doses really helps. And I would say, the levetiracetam, the Keppra, if she has not had seizures for 6 or 7 years, do carry a conversation with her doctor to see whether, sometimes you can also do an EEG prior to considering tapering her off the medicine, to see, how actively you still see interictal spikes. She may have a good chance to be off the medicine. And also for 15-year-old, just to make sure, check the ferritin and iron storage. She's not low in those. If low, supplement that can help her with sleep at night. And also, if someone's on iron supplements, and I would say for many kids with Angelman, they had a risk for constipation. Most of the time you will need to start on fiber supplements, like the natural fiber, like inulin fiber. Those actually are probiotics, would go to the column for the microbiomes.
And then Paula, so with the sleep issues started when she got her period. So again, I would get a set of labs there to make sure there are no issues, iron especially. And then it says you've been giving her the clonazepam, the clonidine for sleep, and can she stay on those? You know, I don't usually use Klonopin for sleep very often. I use other medications. I found them to be more beneficial. Clonidine is more for helping you fall asleep. So if she is having issues falling asleep, that might help with that. I'm uncertain of the risks of staying on those medications. I'd have to look at the data for that. But if she's groggy in the mornings, you know, you might want to look at her medications, but you also might want to look at, you know, I don't know if she has seizures, but if there's seizure activity going on, get in, you know, a longer EEG to see if she has stuff going on at night. Or, you know, meds, seizures, and then kind of check in on getting some labs. I think that's a good, and then if that doesn't work, maybe a sleep study would be a good thing for her, just to kind of see where she's at with stuff. Do you have anything to say, Dr. Fan?
Yeah, so for Paula, I would say the morning grogginess possibly is related with the clonazepam. I don't know what is dose she's on. This is one of the benzodiazepines that has one of the longest half-life. The half-life is like 2 or 3 days. So you're taking this at night, she still has decent amount of that level in her bloodstream. So for a medicine like a clonazepam, if you do a dose change, the overall stable effect will, you know, the steady blood level will take a week or 10 days for you to see. I would say, you know, check the treatable causes like iron deficiency and talk with her doctor to see, this is a pretty hefty medication on both clonazepam and clonidine. Considering to lower her clonazepam if possible, as you know, this is a vast majority of the benzodiazepine, you will last its benefit, you know, you will have a tolerance over time. So I would say, but you know, talk with her doctor. But when this is try to be, if you considering tapering this need to be tapered very slowly. If she's been on that for 3 years, this needs to be done very, very slowly. Typically, give them a month or two, cut down like a quarter or even less than a quarter, and then a month or two. So you need to do this very slowly. Otherwise, she will have a rebound of her problem.
And then Desiree, the white nose, the lullabies, I think those are fine. And I don't see that there's a problem keeping them on all night. And it might help them fall back asleep when they have nighttime awakenings, because that's what, you know, it's kind of lulling them to sleep a little bit and helping them self-soothe is what it's doing. And then Paula with the melatonin, the double dosing for melatonin. Correct me if I'm wrong, Dr. Fan, but so like if you want your kiddo to fall asleep at 7 and they're falling asleep at 9, you would give the melatonin at 7 p.m. and then again, or you would give it, sorry, you want to fall asleep 7. So you give it a couple hours before you want them to fall asleep, and then you give it when they fall asleep.
Yeah. So I will give one dose at the bedtime and 2 hours before bedtime. Some people do 6 hours before the bedtime, but that's really, really hard for parents to know when to give. And we've had many patients try, you know, just one dose at bedtime. If, you know, like 9 o'clock is her regular bedtime, and give another dose at 7. So you will have like 2 staggered dose. And the dose I would do no more than 3 milligrams. I would try 1 milligram one first, you know, each dose given 1 milligram. And if, you know, you can try 3 milligrams if needed, no more than 3 milligrams.
So when your son is up most of the night, and then having a strict wake up time, I always tell parents it's kind of miserable for the first few days, but you want to set that wake up time. If they're up all night long, you still want to get them up on that at that time. And then, you're going to keep them awake during the day and not let them nap if a nap is not appropriate for their age. If they are still napping, you're going to set their very strict nap time. And then because they've been up all night the night before, their pressure to sleep should be strong enough for them to fall asleep that night and sleep through the night. And then you just consistently set that sleep schedule. But I also parents, it takes usually 3 days is what I've been seeing to get them really on that schedule. I have had kids that are really strong-minded, and it takes about two weeks to get them their sleep schedule very consistent.
I totally agree with what Amanda said, for Jessica's question. I think this is related with our circadian rhythm. The one thing our body, our brain really likes is keep a regular schedule, like the time to fall asleep and the time to wake up, and the time actually sets our circadian rhythm more so is the wake up time. So your wake up time for consecutive 3 days will set your time when your brain feels like you need to go to fall asleep. So it's very important. It sounds like a brutal if he or she did not have a good night's sleep, and then you will still have him to wake up at the regular time. I would say even if you want your child to sleep in, typically no more than 1 hour than his regular time. I would say, keep on that regularity. And most people, most of, normal developing people and also kids with Angelman, even if they have a night that they did not have a good sleep, most of them still will be fine, be able to functional during the day. That is the way to keep their sleep and wake cycle on regular basis. So sleep in and a different time should be avoided if possible.
It looks like there's another question from Paula for you, Dr. Fan.
Okay, for melatonin, I know that you said no more than 3 milligrams. For the double dosing, if I have to use 3 milligram melatonin, do I give 3 milligram 2 hours before? Yes, you can. If you use 3 milligram, you can give 1 3 milligram 2 hours before and another 3 milligram at bedtime. The reason for that, actually, melatonin, I forgot to mention, has a very short half-life. It will be gone out of the blood 2 hours afterwards. So it's something, you take or have some effect, it will be gone from the body. So the total of 6 milligram is still okay. If I remember, Paula, your child is teenager. So this should be totally fine. 3 milligram at bedtime and also 3 milligram before bedtime. And Marilyn has a question. My daughter is taking clonidine, but I don't know what her question is. Or maybe we can open up so they can ask questions live. So that would be actually maybe a little easier than they type in.
Oh, I'm sorry, doctor. Unfortunately, we're in a webinar right now, so the
Okay.
attendees won't be able to turn on their camera.
Okay.
Are there any more questions?
I think that's all the questions for today.
Okay.
Great. I think we are on time.
You are. Thank you so much both for